My name is Pedro Salinas, an intensivist and daily POCUS user in the ICU. I have no disclosures relevant to the content of this talk. In these recorded mini lectures, I will review the ultrasound transducer movements needed to obtain the basic cardiac windows and views. The slides are a mix of ASC education material and HeartWorks video that I made. POCUS is an essential diagnostic and management tool in patients with shock, respiratory failure, and cardiac arrest. Basic echocardiography allows you to evaluate LV and RV systolic function, pericardium, and IVC. I truly believe echocardiography and ultrasound is one of the best tools you can learn as a clinician, especially if you take care of patients with hypotension, shock, respiratory failure, and for volume status evaluation. The basic echocardiogram protocol and views are the following. The parasternal long axis view, which is depicted here in number 3. That's where the probe is sitting on the chest wall. There are two depths. The high depth, that is 20 to 24 centimeters, is to assess and screen for pericardial fluid and left pleural fluid. The medium depth, that is to evaluate LV and RV size and function and to assess the pericardium. Here in number 4, you can see that's obtained rotating the probe clockwise and has different levels to assess different structures. You have the pulmonary artery level, you have the aortic valve level, you have the mitral valve level, the papillary muscle, and apical level. With those, you evaluate LV and RV size and function, and also the pericardial space. The other window in the basic protocol is the apical 4-chamber view. Again, it can be subdivided in high depth and medium depth. The high depth will assess and screen for pericardial and pleural fluid. The medium depth centers and assess for LV and RV size and function and the ratios between the RV and LV. It can also be used to screen tricuspid and mitral regurgitation and also assess the pericardium. The next view in the subxiphoid area is the subcostal 4-chamber view. Again, you can visualize structures such as the LV and RV, the size and function, the ratios. You can also screen for tricuspid and mitral regurgitation. And with repositioning of the probe, you can assess IVC diameter and degree of respiratory variation. The transducer movements will describe the motion directed anteriorly, posteriorly, medially, laterally, superiorly, or inferiorly to the scanning planes of the heart. The long axis plane corresponds to the long axis views, where the heart structures are caught in long axis. The short axis plane corresponds to the short axis views, where the heart structures are cut cross-sectionally. The apical plane corresponds to the apical views of the heart. The basic imaging windows described are the parasternal, apical, and subcostal. It is important to get familiar with other terminology used very commonly. One of them is tilting or fanning. So for tilting or fanning, the index marker hasn't changed, so your axis remains the same. However, as you scan from posteriorly to anteriorly, you are going through same axis but different planes, so different structures. So you can see when you have a 4-chamber view And as you aim more anteriorly, by tilting or moving the tail of the probe down, you can open the LVOT and you can visualize the aortic valve and the aorta. When you rotate the probe, you move the axis entirely. So here your index marker is pointing around 11 o'clock. You obtain the parasternal long axis views and the structures visualized here. When you rotate clockwise to around 2 or 3 o'clock, your axis changes completely. Your index marker goes to the right side, and now you are visualizing all these structures cross-sectionally. By sliding, you move the transducer across the patient's skin to a new position, and you certainly change the planes, the structures that you're going to be visualizing. Rocking the probe means going towards the index marker or away from the index markers. You maintain the same image plane, unlike tilting where you go through different image planes. Here you're just centering different structures but in the same image plane. With angling, the transducer is kept at the same location, same axis, but the sound beam is directed to show a new structure. Different than rocking, where the structure is centered, here with this maneuver of angling, you are just optimizing to see the new structure, not necessarily centered. Here is the pulmonic valve, so this is the same parasternal short axis with some angling of the index probe, and the beam, the sound beam, you can see the pulmonic valve better. Let's review your basic windows. We're going to review the parasternal long axis window with your probe and index marker at 11 o'clock. You have your sound beam that is cutting through your structures in a long axis plane with your RB, LV, LA, LVOT, and aorta. You can also see them here, cutting through those structures and how you see it on your ultrasound. Here we have the parasternal long axis view again with your RB, your interventricular septum, your LVOT tract, left ventricular outflow tract, your aortic valve, your left atrium, your mitral valve with your anterior and posterior mitral valve leaflets, and your left ventricle. Again, is one of the basic cardiac windows, your parasternal short axis at different levels. When you turn clockwise your index marker from around 11 o'clock to 2 o'clock, you'll obtain a parasternal short axis. You can see depicted here. This is your sound beam cutting through the heart structures in short axis. We're seeing here your parasternal short axis at the mitral valve level. You have the RB, you have the interventricular septum, your mitral valve with anterior and posterior leaflets. Without changing your axis, but by tilting the tail of the probe down, you're going to be visualizing different structures. So again, your sound beam is in short axis, but now you're looking at more superior structures. You're seeing your RVOT, your pulmonic valve, your RA, and your LA. Different angle maneuvers can bring different structures into center. Here's a closer look of your short axis RB inflow view, LA, RA, tricuspid valve, RVOT, and pulmonic valve. An apical four-chamber view is one of your basic windows. Here at the 5th or 6th intercostal space under the nipple with the marker pointing around 4 o'clock. The 4 cardiac chambers can be visualized. The structures visualized in your 4-chamber views are your 4 chambers, your LV, your left atrium, your right atrium, and your right ventricle with your mitral and tricuspid valve. This is your subcostal window. This is the 4-chamber view, and that's obtained with the index marker around 3 o'clock. This is your sound beam going through the heart structures, RB, LV, LA, RB. This is how the image is generated, but then it's flipped, and this is the way you see it on your screen. Here's a closer look of the structures: interventricular septum, interatrial septum, tricuspid valve, mitral valve, RB, RA, and LB. This is a good view to visualize any atrial septal defects or PFOs. By rotating your index marker from 3 o'clock counterclockwise to around 12 o'clock, the IVC can be visualized. It's important to see the RA in order to confirm that you are actually seeing the IVC. You can see the IVC, the RA, the IVC collapsibility in spontaneously breathing patients correlates with the right atrial pressures. So with inspiration, the IVC drains into the RA and the IVC diameter gets smaller. When the IVC is more than 2.1 centimeters and less than 50% collapsibility, the RAP is said to be between 15 to 20. When the IVC is less than 2.1, collapses more than 50%, the right atrial pressure is calculated between 0 to 5. Values in between are said to be around 10. These are the guidelines used for this lecture. Thank you.